So our speaker today is Dr. Ovi Inamala. So Ovi came to us via Emory and then Ross University Medical School. He is staying on to be a vascular neurology fellow with Dr. Wayne Feng. Ovi, there he is just an adorable, there's only less than 8 in that picture, but an 8-year member of the debate team. I would have absolutely never guessed that. 4 years in high school, 4 years at Emory, that is a big deal. Although the kind of thing that where I grew up, you would have kept quiet. A 2-time national debate champion, and just a phenomenal resident. And we're so pleased to have him here in vascular neurology. Thank you, Will. And he's going to be speaking to us today on medical cannabis in neurology, or as I like to say, how do I sleep at night? All right, let's get your slides up.
Hey everyone, I'm Ovi. I'm a 4th-year neurology resident here at Duke. I'm going to be speaking today about cannabis-based medicine in neurology. I chose this topic, 1, because it'd be a little bit of fun, but 2, because it's sort of a topic that's growing in popularity recently. And there's a lot of sort of hype and bias that surround the topic. But it's especially relevant for us within the world of neurology because all of its medical uses, or at least most of its medical uses, are for neurological diseases. So I think it's something that we all should be educated about, just like other aspects of the neurological system. And I really wanted to present it from an objective, evidence-based perspective, sort of ignore all the hype and bias and sort of see what have we studied so far, what do we know about sort of cannabis endocannabinoid system and its medical uses and risks. And sort of present it to everyone else. That's my goal, but I can't promise that a little bit of bias doesn't sort of mix in towards the middle while I'm doing the presentation. This is an outline. We'll talk a little bit about the science, then I'll school you a little bit about history, and then we'll talk some about the medical uses as well as the risks of cannabis-based medicine. So first, we'll start a little broadly just about what exactly is cannabis. What do we mean when we're talking about cannabis? Cannabis is a plant. Specifically, it is a genus of flowering plants. You can see the entire scientific classification in that picture on the slide. But within the genus of flowering plants of cannabis, there are 3 recognized species: Cannabis sativa, Cannabis indica, and Cannabis ruderalis. Sativa being the taller, skinnier plants with higher THC content. Indica is a little bit shorter and fatter with lower THC content, and no one really ever cares about ruderalis. And they originate in Central and South Asia. But essentially, each one of these plants, so sort of the sativa species, you can have hundreds or thousands of different varieties with different THC or CBD varieties as well. As same goes for the indica plants as well. There's a lot of different routes of administration, which is another part of the sort of cannabis debate that's a little bit difficult because we don't know what the best way to deliver these drugs to patients is. It can be smoked or vaporized. That gives about 30% sort of bioavailability or absorption. But it does wreak sort of peak effect within 5 to 10 minutes, especially within the brain. So you do get a pretty rapid onset. Oral, the onset is later, more like 2 or 6 hours, and you have less bioavailability, 5 to 10%, and it's better with food. And that applies to a lot of the cannabis products. But there's other sort of administrations like sublingual and transdermal that are in prior or future studies as well. The transdermal application has the potential for pretty good absorption. So the cannabis plant, the leaves actually on the plant aren't the part that we're looking for. What we actually look for are the oils that are secreted by things called trichromes. And these are these little hair-like projections on the cannabis plant that you can see in that picture on the bottom right, the little mushroom-shaped projections. They secrete oils that have cannabinoids, terpenes, flavonoids, a bunch of organic compounds, and all of them have various physiologic effects. So the 2 main cannabinoids are the ones that you guys are probably most aware of. So THC, delta-9 tetrahydrocannabinol, that's the main psychoactive compound. That's the one that gets you high theoretically. And the second one is CBD, and that's the one that, at least in recent times, is becoming more popular for its medical uses because it has anti-inflammatory, anti-anxiolytic, anti-epileptic, as well as several other effects. But those aren't the only two compounds that come from the plant. There are there are over 400 known compounds in the plant, including a lot of other cannabinoids and these terpenes and flavonoids that I mentioned as well. So there are three important slides and lessons in this presentation, and this is number one. That's why it has the little thumbs up guy in the top right corner. That we have an endogenous system that we call the endocannabinoid system, or the ECS, that was discovered by some Israeli scientists in the 1960s or 70s. And essentially, our endogenous endocannabinoid system is comprised of the following things. One being endocannabinoids. So just like THC and CBD are cannabinoids, we actually have endogenous molecules within our body that work as cannabinoids. And the two main ones are anandamide and 2-AG. And they're arachidonate-based lipids that bind to the second part of the endocannabinoid system, cannabinoid receptor proteins. All right, there are a lot of receptors that have been postulated as being involved in the endocannabinoid system, but the two main ones to be aware of are CB1 and CB2. And these are both G protein coupled receptors. So when one of the ligands, whether it's an endocannabinoid or a phytocannabinoid from a plant, binds one of these receptors, you have sort of the downstream reaction that you expect from G protein coupled receptors. Now, CB1 is the receptor that's associated with THC. It's sometimes called the THC receptor and is mostly within the brain and the central nervous system. CB2 is found a lot more peripherally in blood cells and our liver and spleen and a lot of our immune cells as well. So that's why there's the split between the psychoactive brain effects as well as some of the peripheral effects like anti-inflammatory things and the effects on blood cells. There are enzymes that build these endocannabinoids, that degrade them. And of course, there's all the locations that these receptors and molecules are. And a lot of it is within our neurons and our neural pathways, within our brain, our central and our peripheral nervous system, which is the reason why I think understanding this system is really so important to neurology now, but also the future of neurology as we discover how it's involved in more of the diseases. And and this whole system is involved in regulating a lot of our physiological processes, not just what I've talked about, but motor learning, the immune system, appetite, of course, our sleep and wake cycles, mood and memory, fertility and pregnancy, and of course, pain and cognitive processes. And so this is a picture that sort of shows you where some of the receptors are found throughout the body. There's a lot in the gastrointestinal system as well. So there's a lot of research going on in inflammatory bowel disease that I won't talk about that also is using cannabinoids as therapy. So this is an example. On the left is a picture of a bunch of the phytocannabinoids. So like I said, there's THC and CBD, which are the main ones we know, but there are a bunch of other cannabinoids. And if you go to like a cannabis dispensary, they'll usually have a chart and tell you for each particular plant how much of the different cannabinoids are present there and what their physiologic effects are, whether or not it's more relaxing or anti-inflammatory. Some of it based in good science, some of it probably based on a little bit more of folklore type of stuff. And on the right is a list of all the cannabinoids, including sort of the synthetic ones. There's a list of phytocannabinoids, but also the endogenous cannabinoids that we talked about as well. But you can see in the synthetic list over there, we have Marinol, which is one of the approved medications that we can use, but that is a synthetic cannabinoid. So it's not from a plant. It's not from our human body. That was something that was made theoretically in a lab. And each one of them, each different cannabinoid has a different amount of activation for CB1 and CB2 receptors. And there's even some drugs that are approved in Europe that are CB1 and CB2 antagonists. There's a CB1 antagonist that is approved for weight loss. So the point is, when you have medications that affect the endocannabinoid system, it's much more than just smoking a joint of medical cannabis. There's a bunch of different drugs that can interact with the system in a bunch of different ways that are potentially usable for modern medicine. Okay, to talk a little bit about the history, I won't go too much in sort of the random stuff that's occurred over time or in the ancient history of cannabis, but I want to talk at least about the important evaluations or studies or reports that have been done on cannabis over the history of time, and starting with 1894, when India was colonized by Britain, and there was a lot of cannabis usage within India. They used to make a drink called Bang, basically. That was a low cannabis drink, but still a lot of people used it at the time. And the British Britain at the time was concerned about the amount of use, so they compiled a massive research project with almost 1,200 authors. It was multiple thousand pages long to try to figure out if there were any ill effects from the prolonged use of cannabis. And they came to two key conclusions. Moderate cannabis consumption is harmless or could be beneficial, and cannabis prohibition would be supremely unjust, as they phrased it. And you can Google the entire report. It's online. I had it pasted here, but then I deleted it because it was way too long. I know there's a lot of text, and I apologize, but just two important things from this. In 1944, the LaGuardia Report. That was the first study, it's a big study done in America in response to the reefer madness sort of era of campaigning against cannabis by Harry Anslinger at the time. So there was a big report that was led by the New York City mayor, LaGuardia, at the time. There were a bunch of doctors and psychiatrists, psychologists, and they did an investigation of cannabis to sort of respond to the anti-cannabis movement, and they sort of determined prolonged use does not lead to physical, mental, or moral deterioration, and that they said that it shouldn't be sort of criminalized or anything like that. And then the other one at the bottom, 1972, the Schaefer Commission. This was in response to the Controlled Substances Act in 1970. The 1970 Controlled Substances Act is what made cannabis or marijuana a Schedule I drug, which means that it's not sort of usable for any medical use at all. And the Schaefer Commission led a study after that, and it was hired by Richard Nixon to sort of hopefully support what was done in the 1970 Controlled Substances Act, but they came to a similar conclusion as well, that the societal harms caused by cannabis were limited, and they recommended no criminal penalties for use or distribution of the drug. And then in terms of recent history, the most important thing is that it was tide is starting to turn in the opposite direction. It's getting legalized in other countries around the world, like Uruguay and Netherlands, that were leading the movement. And now at least 26 states, I think this number is higher now, have either fully or partially decriminalized certain marijuana possession crimes. And the terms are used interchangeably, cannabis and marijuana, but marijuana really refers to the term of the dried buds covered with oil that people sort of smoke in the end process, and cannabis refers to the plant. But some people say there's some racist connotations to marijuana because a lot of this was used to arrest sort of immigrant Mexicans over the years, and so people are preferring the term cannabis more recently. All right, now I'm going to start sort of delving into the medical uses. Part one, sort of the big thing that has put cannabis and medical cannabis at the forefront is its use in epilepsy. That's where probably a lot of us have seen it during residency. And the story about medical cannabis for epilepsy starts with one girl and one family, Charlotte Figge and her family. So I'm going to tell her story real quick, and then we'll look at some of the evidence. So Charlotte Figge was born in 2006, and at age 3 months had her first bout of febrile status epilepticus, and then sort of developed ongoing seizures for a majority of her life. She was up to 50 tonic-clonic seizures per day. And then she had genetic testing done for Dravet syndrome and tested positive, the SCN1A gene mutation, and then had significant amount of developmental regression. She needed a feeding tube. She had limited speech. She had trouble with ambulation and had maxed out on 10 anti-epileptic drugs and a ketogenic diet, and had left her parents sort of really frustrated with our ability to sort of manage her epileptic condition. Dravet syndrome, for those of you that are less aware, is a pediatric epilepsy condition that's particularly challenging. You get really bad seizures and febrile status that's intractable to medications, that begins really early, around 6 months, and also has significant amount of developmental abnormalities as well. Very refractive to AEDs, and outcome is typically very poor. And they have this sodium channel mutation, SCN1A mutation, that it shows in the bottom right, that leads to less sodium channels present on your nerves. And so they moved to Colorado and met the Stanley brothers. And what the Stanley brothers had done is they bred a specific type of cannabis that was very low THC and high CBD ratio. So people had been breeding low THC cannabis for a long time for hemp. And the definition of hemp is usually less than 0.3% THC, but they usually have low CBD levels as well. And CBD is the one that's thought to have the anti-epileptic properties. So they bred a strain that was low THC, high CBD, and the thought was this could be given to a child because without THC, you don't have the psychoactive components that they're afraid of given to children. And they did it via a sublingual administration with an oil, and at about 4 milligrams per pound or 2 mg per kg, she had a 90% reduction in seizures, down to 2 or 3 per month. She was able to stop all her other AEDs. She learned to walk. She started to eat. She was able to remove her feeding tube. She had improvement in her development. And they actually named the strain of CBD after her. It's called Charlotte's Web, and it's still used to this day. And that sort of pushed for a big awareness movement across the country, where now a lot of states are pushing for medical cannabis. And it starts with epilepsy, but as you'll hopefully learn, there's a bunch of other conditions where this can be used as well. So this is pictures of Charlotte Figge. She actually passed away recently of pneumonia like 2 months ago during this whole time. And she was actually COVID tested and was negative, and CNN did another big special about her. Sanjay Gupta has done like literally 3 or 4 specials about her over time, and her family, the ones that helped her sort of get the treatment that she needed. So this is a trial that was done on Dravet syndrome. This was up in Canada and was actually CBD and THC. There are other trials that were done, but this is just one that where the results were particularly significant. So I thought I would share it. Now it is they used a compound TIL TC 150, and it's much more CBD than it was THC. 100 milligrams per milliliter of CBD and just 2 milligrams per milliliter of THC. But they did give it to children with Dravet syndrome, and they had a median motor seizure reduction of 70%. 50% responder rate of 63%. But more so than just the reduction in seizures, there was an improvement in quality of life, an improvement in their sort of developmental abnormalities, reduction in bad EEGs. There were some adverse effects, and I want to try to highlight these throughout these presentations so you know that there are risks to taking the medication. It is not something that's just a cure-all without any type of risk. So the biggest adverse effects in this study were somnolence, anorexia, which was surprising to me, and diarrhea. And patients that were also on valproate had liver and platelet abnormalities. Liver abnormalities are a common theme for this medication, so it's something you should always monitor in your patients if for some reason you have them on a cannabis-related product. Lennox-Gastaut is another pediatric epilepsy condition that presents a little bit later in life than Dravet syndrome, between the ages of 3 and 5. Its sort of typical characteristic is it has multiple seizure types. One of which is atonic seizures that causes a lot of falls and a significant amount of disability and morbidity as a result. Fairly refractory to anti-epileptic drugs and the ketogenic diet, and typically results in intellectual disability as well. I'm going to show you 2 trials about Lennox-Gastaut syndrome and cannabis-related drugs. This is the first one that was published in Neurology in 2007 for just testing CBD. This is the first big CBD trial for Lennox-Gastaut syndrome. And this was sort of a multi-center randomized double-blind placebo-controlled trial. Now, placebo control is very difficult in the world of cannabis-based medicine, especially for the ones that have THC, because there's a psychoactive or a high component. This was at least just CBD, but also there's a smell and there's a flavor to it that maybe it's a little bit more effective in children. But regardless, they usually do give it a try, and they did in this particular case. And CBD resulted in a significantly greater median percent reduction in monthly drop seizure frequency. So they looked at drop seizures specifically, versus placebo, 44% versus 22%. And this was statistically significant. And you'll see this sort of percentage distribution, cannabis in the mid-40s and placebo around 20% for a lot of these studies, where cannabis is about twice as effective as placebo. So it'll be a recurring theme. Adverse events that were common: diarrhea, somnolence, pyrexia or fever, decreased appetite, and vomiting. So you can see that CBD doesn't really have a lot of the appetite components that THC does. It sort of works a little bit in the opposite direction. So CBD add-on therapy for treatment of drop seizures may be efficacious and generally well tolerated. This is another trial that was published the next year in May 2018 in the New England Journal of Medicine. A trial, this was just a CBD trial as well, and showed 20 milligrams of CBD per kilogram of body weight had 42% fewer seizures on average, compared with a 17% reduction in placebo. And this again was focusing on drop seizures for patients with Lennox-Gastaut, and similar side effect profile, but these patients also had elevated liver enzymes as well, which is why we still monitor liver enzymes for any patient on CBD containing compounds. And so Epidiolex became approved after that. It's the first medication approved from the cannabis plant in the United States. So Marinol is approved, but that is a synthetic cannabis or a synthetic THC. But Epidiolex is actual CBD from a cannabis plant dissolved in sesame oil and a sweetener. And it's 100 milligrams per milliliter of CBD, and it's approved for both Lennox-Gastaut and Dravet syndrome. It's not perfect, though. There are some sort of costs or some drug interactions that you have to take into account when prescribing CBD-containing compounds. And the most important of which is its effect on on-fee levels. So this was a study published in Epilepsia in 2015 that showed that CBD use not only increases clobazam or on-fee levels by about 60%, but the metabolite of on-fee and desmethylclobazam, which is the active metabolite, increases by about 500% or at least 300%. And so a lot of patients have too much levels of this in their body, and they tend to get symptomatic and have side effects, and you have to titrate the clobazam levels, not only based off levels, but based off their side effects and the whole seizure profile when you're taking this. And some physicians really like the use of on-fee. It's a really good drug for seizures. And so it makes some people sort of shyer about using CBD-containing products. And it affects the levels of other AEDs as well. This was another study in Epilepsia in 2017 that showed it doesn't only increase clobazam and its metabolites levels, but there's also mild increases in levels for topiramate, rufinamide, zonisamide, and eslicarbazepine. We know that cannabis is metabolized by the liver and does affect various CYP enzymes in different ways. So that's why we think they have the metabolic effects. And patients on valproate also had elevated LFTs. And there was another study done that Dr. Radke was talking about that I didn't include in this presentation that showed that CBD works well for seizures, but it isn't dramatically better than Onfi or Topamax. So it's not sort of a life-saving grace that some people make it out for. It is a medication that can be used, and particularly in individualized situations. That's one of the things about the medication is for some people it works great, and for some people it doesn't. You have to figure out which person it's most appropriate for. But it isn't something magical that should replace all the standard anti-epileptic drugs that we use. And this is sort of a summary of a bunch of studies that were done. I know that this is really hard to read because it's a big chart, but this is essentially about 15 studies on the use of cannabis within epilepsy, particularly in TRE, which is treatment-resistant epilepsy, so the severe versions, things like Lennox-Gastaut and Dravet syndrome. There's one on tuberous sclerosis and other epileptic encephalopathies on the use of either CBD or CBD and THC-containing compounds, and most of them have about somewhere between a 40 or 60% reduction in seizure frequency, but it goes as high as 80% in some of these studies. So just pointing out that there's a lot of literature on this particular subject.
THC have an effect on seizures?
So THC was included in some of the studies. It has not been studied independently as far as I know. Usually any study that includes THC is a combination THC-CBD, but it seems like CBD is the drug that we believe has most of the anti-epileptic effects.
Have they actually studied
Not that I've seen independently of THC, yeah. Brief intermission before we move on to the next section. I thought of 100,000 funny names for this presentation because of the topic at hand, the simplest of which was chief talk, because chiefin is a term used for the use of cannabis, and a couple of others, but I'll go ahead and move on since we lost a little bit of time. Higher education, yeah, a couple of these are great. One of these will end up being the name of the book I write about this topic, for what it's worth. Part 2. So this is the part that I at least feel strongest about and has at least the second sort of important slide and lesson for this presentation is pain, opiates, and nausea. I hate the way that we manage pain in the modern medical system because of how sort of diffuse and we've used opiates for so long and how nasty those drugs are with their side effects and the potential for opiate overdose. This cartoon is hilarious, but also I think extremely compelling when people come for pain management. There's lots of drugs that we could potentially use that can treat pain and have limited side effects, but instead we sort of keep fueling the opioid healthcare machine and make a lot of our patients addicted to opioids. And then when we try to wean them on, it creates a malignant relationship between providers and our patients. And it really is one of the worst parts of residency is dealing with some paid patients and because of the drugs that we have to use. And I think that cannabis provides some hope for better drugs that can be used more therapeutically and create sort of a more positive relationship between providers and patients as well. And so it works particularly well for nerve-related pain, and that's why it's great for us. And that story starts in the early 2000s when it was studied on a bunch of HIV patients. So before antivirals for HIV were really widespread or really effective, HIV patients that progressed into AIDS would have really bad sensory neuropathies that would develop. And in early 2000s, in 2006, 2007, this one was published in Neurology in 2007, a couple of studies were done on actual smoked cannabis and its efficacy in terms of controlling neuropathic pain for these types of patients. And this was actually randomized with a placebo. They had placebo cigarettes where the cannabinoids were extracted, and they smoked it 3 times daily for 5 days. And you can see on the chart on the top left, I know it's a little bit difficult to read in the small text, but there was a 7-day period where they didn't give them the drug where it's about the same. And then there was a 5-day treatment period where you see the dramatic drop in one of the two curves. That's the line where the patients were given cannabis. And then after 5 days, they stopped the cannabis portion of the smoked cigarettes in that treatment arm. And you can see their pain levels coming back up. Now, all these are measured as VAS, which are sort of visual associated scales. Which is basically, a lot of these symptoms that we study for cannabis are subjective, so they're hard to study. So they just give them 0 to 100-point scales, and they use that to subjectively evaluate pain and measure it over time. And then you can see some of the side effects in the bottom left: anxiety, sedation, disorientation, paranoia, confusion, dizziness, and nausea were the big side effects reported in this particular study. And then this is another study that looked at the use of cannabis in neuropathic pain. But this one was cool because they used fMRIs as well before and after to try to figure out what part of the brain was getting affected. So you can look at the visual analog scale in the bottom left as well to see the difference in their pain levels from 0 to 100 before and after for THC and placebo. You can see a bigger drop in the THC curve, which is in the left or in the bar graph, compared to placebo, and that was statistically significant. But then they did fMRI on the brains before and after, and they saw a connection between the anterior cingulate cortex, the ACC, and the dorsolateral prefrontal cortex and our somatosensory cortex, or the sensory cortex, or we'll call that the DLPFC. And they saw that there was a reduction in the connection between these two for patients that were using THC in chronic pain, and they postulated that that could be the mechanism for pain reduction for patients that are taking a THC. But this is focused on THC, not the CBD components. This is another meta-analysis that was done on chronic pain. They took 7 or 8 studies on the use of cannabis for any type of pain, didn't necessarily have to be neuropathic pain, and did a sort of a systematic review and a meta-analysis. And you can see the overall size was negative 0.61. The confidence interval did not pass 1, so there was a statistically significant effect on chronic pain. There's some evidence that it can be useful for headaches and migraine as well. This article sort of summarizes a bunch of case studies and case reports. There's no like big RCT that's been done. I'll show you those on the next slide. But this picture on the bottom is at least their postulated mechanism for how cannabis or the endocannabinoid system can contribute to headaches and migraine. And so what they thought was that some patients that have migraines actually have an endogenous endocannabinoid deficiency that can lead to increased glutamate signaling, spreading cortical depression, and then that can trigger an actual migraine. But there's other things involved as well, like it can cause platelet instability, and it can affect sort of your perception of pain as well. And then this is a summary of a lot of the studies that have been shown for headaches and migraines. Now, a lot of these are case reports on the left, 3 patients or 5 patients or maybe just one. There is one towards the bottom, a retrospective study of 121 patients that were prescribed cannabis for migraines, and migraine recurrence decreased from 10 to 4 per month. And on the right, these are sort of bigger surveys, more so than anything else, of people with bad headache conditions that used or were given cannabis. At the top is the biggest one, 1,655 patients that were using medical cannabis, and about 40% reported improvement. And on the bottom right was actually 112 patients with trigeminal neuralgia, and 70% found relief with the use of medical cannabis. Just shows how effective it can be, because all of us that have gone through neurology residency know how challenging patients with trigeminal neuralgia are and how many medications we typically have to use. And 90% of them found chronic relief. Fibromyalgia, another difficult to manage condition because we are not sort of fully confident in the pathophysiology. This is another study that shows that cannabis use can be pretty effective in these patients. You can see the chart on the right, and this is another visual analog scale, because a lot of these things, like I said before, are subjective symptoms, which is what makes it difficult to study. But pain and stiffness had a dramatic reduction in patients with THC, and they had an increase in relaxation, somnolence, and general well-being. And you'll see with a lot of these studies, but the one thing that increases a lot is just the quality of life for these patients. Maybe if, it helps with their symptoms, but also helps them maybe care less about their symptoms or something like that, so they can sort of move on with their life, especially in these pain-related patients. So opiates, like I said, this is a topic I feel strongly about. I really hate prescribing these medications, or hate the fact that a lot of our healthcare system has hooked a significant portion of our population on this as a super addictive drug with horrible side effects. And the big thing I've learned with doing a lot of this reading about medical cannabis is that as medical cannabis increases, opiate use and opiate death decreases. I'll show you 3 studies about it. This is the first one that was published in the Journal of Pain back in 2016. That looked at medical cannabis patients that were originally opioid users, and medical cannabis use was associated with a 64% decrease in opioid use, and a decreased number of side effects of the medications, and an improved quality of life of 45%. Now, this is the DENT study. This is what came out recently, and is actually what initially sparked my interest into the use of cannabis for pain and replacing opiates. It was sort of one of those things that was spread around Medscape and a bunch of emails around last year. It was published in April of 2019, and it was done by the DENT study up in Philadelphia. That was a retrospective review of a geriatric population between the ages of 75 and 100. And again, I apologize for how small some of this text is. But 70% reported a significant increase in their quality of life, and more than 30% were able to stop taking their opioid painkillers. And it helped with symptoms like chronic pain, sleep, neuropathy, and anxiety in particular. Opioid pain medication was reduced in 32% of this population. So a lot of people were able to get off their opioids and use cannabis. And a lot of people postulated that not only is cannabis effective in terms of pain relief, and that's why it helps, but it also helps in your reward center so that you can get over prior addictions as well. This is smoking. So this was done from the New York, or from like a New York State database where they get medical cannabis, and most of these people are smoking it. Yeah. So this is the important slide in lesson number 2 for me. And this is one of my favorite studies that was done by Dr. Bashbauer and his group over in LSU about medical cannabis laws and their association with opiate analgesic overdose mortality. So they're not just serving patients and asking them, hey, you smoked cannabis, how did that affect your opioid use? But they actually looked at a period between 1999 and 2010 and looked at how cannabis laws changed in states over time and how that affected the rates of opioid overdose deaths. So in the beginning, there were 3 states, California, Oregon, Washington, with medical cannabis laws. At the very end, 10 states had enacted medical cannabis laws during that time. And they did a year-by-year analysis to see how many states legalized medical cannabis in a particular year and how the rates of opioid overdose deaths changed over time. And what they found was a statistically significant association between medical cannabis laws and significantly lower state-level opioid overdose mortality rates. So just having the law and passing the law has a statistically significant association with lowering opioid overdose deaths within your state, which for me is particularly powerful. And feel like for every day or so that we're waiting in North Carolina to pass laws like this, more people are dying as a result. And you can see the chart on the left that shows the change in mortality rates over time and years after implementation, and how it changes from about the negative 20% to about negative 40%. So they say about a 20 or 25% reduction in the mortality rate as a result of having medical cannabis laws within your particular state. So I really think it needs to be spread to more states as a result. Nausea is another big topic. This, I think, was a really funny story, so I thought I'd incorporate it. There was a Harvard Medical School professor, Dr. Greenspoon, that back in the 1960s was actually pretty anti-cannabis and was friends with Carl Sagan, a famous astronomer, and tried to convince Carl Sagan to stop, quote, smoking so darn much of the stuff. But then his son was diagnosed with leukemia at the age of 15 and actually had a bunch of chemotherapy and a significant amount of nausea. And I'm going to read this paragraph because I think it's hilarious, but also powerful. But on a normal day of chemotherapy, I hoped we could make it home from the hospital before Danny's vomiting would start, Danny being his son. And we always had to put a big bucket next to his bed. But the first time he tried taking a few puffs prior to a round of treatments, he got off the gurney and said, "Mom, there's a sub shop in Brookline. Could we stop for a sub sandwich on the way home?" And all I thought was, wow. It really shows how powerful this works as an anti-nausea medication, how it can stimulate appetite for patients that are in need. And after that, he actually became a pro-cannabis advocate and helped sort of publish this study in the New England Journal of Medicine. It was eventually published in 1980 that compared THC to prochlorperazine for the use of chemo-related nausea, and showed that THC was just as effective as prochlorperazine, but patients tended to prefer it significantly more to prochlorperazine for nausea, and had a higher proportion of complete responses and more finishing their chemotherapy as a result. So part 3 is medicinal uses for multiple sclerosis and spasticity. There's a lot of MS research, and a lot of MS patients are young and have difficulty with a lot of vague symptoms like stiffness and spasticity that are really tough to manage. And right now we use a bunch of strong medications like baclofen and muscle relaxants that are quite sedating and have their own side effects as well. And so there's a bunch of studies on this subject. This is one that was published in the European Journal of Neurology back in 2007, a randomized control trial of cannabis-based medicine and spasticity. And here's a chart that just shows the difference in sort of the NRS spasticity score for cannabis patients versus placebo. And you can see that there's a dramatic difference in the beginning, and then it stays significantly lower for cannabis patients compared to placebo patients. Here's a list of the side effects on the left as well: dizziness, fatigue, urinary tract infection, dry mouth, and some balance impairment and nausea as well. Those are sort of common side effects seen in a lot of these studies. Here's another study on stiffness in MS published in the Journal of Neurology, Neurosurgery, and Psychiatry back in 2012 that showed the rate of relief from muscle stiffness after 12 weeks of cannabis compared to placebo was almost twice as high, 29.4% versus 15.7%. And it met its primary objective to show that cannabis medicine was effective in treatment of muscle stiffness in MS. Here's a study of central pain in MS and use of cannabis treatment. I showed you a bunch of other studies that were relevant to pain as well, but you can see the curves on the right that their numerical rating scale for pain, as well as mean neuropathic pain scales, were significantly lower, and the curves got lower for cannabis-based medicine compared to placebo. And this was a systematic review that was done for pain and spasticity that looked at 11 different reviews from 32 different studies and compiled it and found out that cannabinoids may have modest effects in MS for pain and spasticity, and that there needs to be a bigger role of cannabis-based medicine within the world of MS treatment. And this was published in the Neurology of Systemic Diseases back in 2018. And the last slide about MS is it can be helpful for bladder dysfunction as well. This was a trial done back in 2004, so kind of an older trial that just looked at urinary frequency during the day and overnight for patients that were given THC or THC and CBD containing compounds. And they found that patients' quality of life and urinary frequency significantly improved, but they also had improvement in patients' self-assessment of pain, spasticity, and quality of sleep as well. So now I'll briefly go through some other potential uses of cannabis, and I'll briefly talk about the risks, and we'll call it, and that'll be the end of the presentation. So the first thing I want to talk about is tumors. If pain and epilepsy are kind of the floor of what cannabis can do in terms of medical treatment, this is the ceiling. There's a lot of mice-based studies or animal-based studies that show potential anti-neoplastic activity of cannabinoids, and I was actually surprised by the validity or the results of a couple of these studies. And this is somewhere where there's a lot of hype on both sides, but particularly the pro-cannabis movement sometimes does say things like cannabis cures cancer. That's absolutely not true. You can't cure cancer. It's a very heterogeneous group of diseases. But cannabis does potentially have a role as a therapeutic treatment for some cancers. I think that would be an accurate statement. So here's two mice or animal-based trials. The one on the left published is an older trial back from 1975, and the one on the right is more recent in 2000. And they're both showing the use of THC can retard tumor growth within mice patients. The one on the right is specifically for gliomas, malignant gliomas in Wistar rats without any neurotoxic effects. And you'll see that of all the different tumors that this could potentially be used for, the neurology or neuro-based tumors are the ones that it's the most effective for, has the most literature for. There's a lot more evidence that's being accumulated. This article from 2018 and reviews some of the potential mechanisms for how cannabinoids can maybe be used for glioblastoma in terms of decreasing tumor growth, increasing apoptosis, decreasing tumor invasion. And then this trial was done in the United Kingdom. And this was when I was really surprised to find, because it was actually a randomized controlled trial of cannabis-based products compared to placebo in combination with temozolomide for patients with GBM. And median survival in the placebo group was 369 days, but greater than 550 days in the CBD THC treatment group. And 1 year survival was better in the group that got CBD THC groups, 83 versus 56%. So I'm actually surprised we don't use it more commonly for brain tumors after I saw this study, unless there was something that I was missing. I'm not sure if they use it clinically in the United Kingdom where this study was done as well. Stroke, there are some potential uses. Some people think that it could be neuroprotective. CB1 receptors, if you activate them, you get an inhibition of glutamate release, decreased intracellular calcium, potentially hypothermia, and decreased reactive oxygenation species. And so there have been some mice studies done that showed that infusion of cannabis can decrease infarct size, but there have been a lot of animal studies done on potentially neuroprotective drugs or compounds in the context of acute stroke, and none of them have translated into human clinical trials. That's really been a challenge. But the potential for cannabis that I think is particularly powerful is in the bottom corner on the right. It says in the same study, the drug also reduced body temperature in a dose-related manner. And I know there's a lot of neurocritical care physicians that are really looking for drugs that potentially reduce body temperature without causing a lot of the shivering that's associated with cooling people. And I think cannabis has that potential. And this is some of the mice studies that was done on the cerebroprotective effects of THC-containing compounds. In this study, they actually gave mice MCA strokes and measured infarct growth with and without THC, and found that with THC, the infarct growth size was smaller. It can be helpful for older patients with Alzheimer's dementia, particularly in stimulating their appetite and helping them go to sleep. In this study, they actually did, halfway into the 12-week study, they switched the treatment groups from one to the other to actually prove that it was statistically associated with the use of dronabinol, the improvement in appetite, the improvement in weight, and the reduction in sort of behavioral problems. And they actually found that it did improve in sort of all three of those things. They actually think that one of the reasons patients gained weight is because there was such a smaller amount of agitational disturbance that they were burning less calories and they were eating more. And as a result, there was more weight gain in a lot of these patients and just better behaviors and better quality of life. This was a survey that showed that there was some improvement in Parkinson's disease for people in terms of just their symptoms in general, but 30% had improvement in their tremor, 44% had improvement in bradykinesia, 37% improvement in rigidity, and even 14% had improvement in their drug-induced dyskinesias. But this was just a survey of Parkinson's patients that use cannabis. It wasn't actually a prospective trial or anything like that, but it has the potential to at least improve quality of life, I think, in Parkinson's patients. And then I did find a trial on concussion, but with some of the cognitive fog that comes with cannabis, I'm not sure giving cannabis to concussion patients would exactly be the best idea, so I won't harp on that too much. And then quickly at the very end, I just want to talk about the risks and side effects just so I can talk about both sides of the issue. And first and foremost, I want to talk about stroke. And this, for me, this is an important slide in lesson number 3 out of 3 for this presentation, and that there is a risk of stroke with use of cannabis. Dr. Dodds, when she was here, used to talk about this a bunch, how there were a lot of young patients that have been coming in with sort of cryptogenic stroke that can't be explained, that was temporally associated with use of cannabis. And there were a lot of published case reports off this of cases like this where people thought that cannabis may have caused stroke in these younger patients. And this was actually published in 2015 in Stroke, where they analyzed 34 different case reports with at least 60 different patients. In most cases, they said at least 80% had a temporal relationship between cannabis exposure and the index event, and at least 70% sufficient workup was done that excluded other causes. Now, in all the other trials I showed you, there was no significant risk of stroke in the cannabis treatment arm for any of those, studies compared to placebo. So I don't know if this is actually causal or if this is younger population just using cannabis and then having cryptogenic stroke for other reasons. But it definitely deserves to be thought about and warrant sort of further investigation and bigger cannabis trials. Because as we move towards recreational cannabis in a lot of states, we might see side effects like this start to come up. And it's true that it's sort of impossible to die from an overdose of cannabis, but if it can contribute to stroke, and I even saw some articles for myocardial infarction, it could definitely contribute to morbidity and potentially mortality in other ways as well. There's definitely some neuropsychological deficits in long-term users. So you have to think about this, especially like if you're trying to give it to MS patients that have some cognitive fog from the get-go. This is a study that was done back in 2006 and published in Neurology that tested various aspects of your cognitive domain, including your verbal language and fluency, your executive functioning, and they found a lot of different cognitive domains appeared to deteriorate with increasing years of heavy and frequent cannabis use, so it's something to be aware of. There are cardiovascular effects. In particular, early use of cannabis for new-time users will increase your heart rate and drop your blood pressure. It says slightly increased supine, but it causes significant orthostatic hypotension and syncope. So there's a lot of case reports of syncope as a result of cannabis use. In fact, I've seen a patient in my clinic as well. And you can really get significant tachycardia that can cause a bunch of anxiety and sometimes even panic attacks for patients with THC use mostly. This isn't as much in the CBD population, so something to be also aware of. And then last but not least, a lot of you guys have heard of cyclic vomiting syndrome, also called cannabinoid hyperemesis syndrome. It's a syndrome characterized by chronic cannabis use, cyclic episodes of nausea and vomiting, and the characteristic sign is they feel better with hot baths, so another side effect to be aware of. So that's it. I wanted to thank a bunch of the faculty. Dr. Radke, he helped me with this presentation quite a bit. The program directors that have tolerated me somehow for 4 years, Dr. Eckstein and Dr. Sinha, a bunch of attendings that have helped me with research projects, people in my vascular neurology department, people I've worked with as an inpatient. I somehow forgot to put Dr. O'Brien's name here, but the chair of neurology has been fantastic for so long as well. And everyone here, and I've probably missed a bunch of attendings, have been super supportive over my career as a neurology resident. My fellow residents definitely couldn't have done this 4 years without them. I couldn't have had a better group of people to work with throughout this time, to be my partners and everything throughout this learning and educational process. I wouldn't have traded any of them for anyone else. And that's it. If anyone has any questions, they can ask now. That's my email address at the bottom.